Thank you very much indeed for inviting me to talk. Got quite a crammed hour to talk, if that's okay. I'm going to take you through some neurodevelopment, psychopathology, and then medication. And if we have time, I've got a very interesting video to show, possibly after 12, but it's up to you whether you want to stay. Very important subject. But this slide you'll know very well. This is from Gede's work and Rappaport in the NIMH, United States, showing that in normal people, and that's a slide at the top, there is a progressive loss of gray matter as you go through adolescence. And this happens in you as well as your children and so on, things like that. It is likely to be due to loss of synaptic connections. And that's in the normal brain. Here is those with childhood onset schizophrenia who have a greater loss of gray matter, greater loss of synaptic connections. And this is in the area of level 3 in the brain. Synaptic connections are most prominent in relation to the treatment of psychosis. And here we have a rather poor slide, I think, really, but showing that in the early part of development, the synaptic connections increase, reach a peak, and then in early adolescence to later adolescence, there's a loss. And that is due to reorganization of the brain. The analogy is if you have a telephone system, and in this room I would connect in early life due to environmental genetic programming, every one of you. But in adolescence, I want a more programmed, fit connection so that I can make certain connections and lose other connections and things like that. So the brain becomes more efficient. And that's in the normal brain. And you can see this here, and this rather interesting slide of here, on that side here, as a loss of synaptic connections as you progress. But the important thing is important connections are maintained. Oh yeah. This is what happens in schizophrenia, with here increasing myelination that goes on until later than we thought, but here prefrontal excitatory synapses are lost, inhibitory synapses are also lost in those with schizophrenia. So the balance between inhibitory and excitatory synaptic connections are changed. And this is some of the same kind of, the slide here shows here, the same things we saw before, but showing that probably there are different sets of influences here. Genetic influences early on, environmental influences, altering this process. The trouble with schizophrenia and psychosis is it's a complex interplay of many factors. That's why it's been much more difficult to target treatments, effective medication treatments, as well as psychological treatments. And this is the way that psychosis may well present and some of the influences that one sees. For instance, early on you get genetic factors, childhood trauma, urban living, and so on. And those at the bottom here, you can see here the influences they may well have. Synaptogenesis, synaptic pruning. And this is how it portrays to you as a clinician, with gradual negative symptoms. The boy at the back of the class who doesn't say anything and just wilts away, that's a very poor prognostic sign. But then you get the overwhelming positive symptoms where he stands up in class and says, I've got the answer. I know now how to, the fourth dimension interface with the other dimensions in physics. And this boy has actually been quiet and not said anything for months. So that's how. And you can get beforehand, and this is how the early intervention psychosis blips along the way that actually may convert to psychosis. Not always, probably about a third of the times. So that's the overall picture. And these rather schematic diagram here shows how all these influences cause stress and effectively impinge upon the synapse here. And we thought we knew the answer in terms of dopamine early on. Now we know it's dopamine, glutamate, GABA, and so on. It's a combination of these neurotransmitters, but the pathway in seems to be very interesting. And here, the paper I recommend really by Rajua, showing the odds ratio of that. So obstetrics complications to a degree, yes. Childhood trauma, which we didn't really recognize until quite recently. Migration, first generation. We see a lot of that in London, for instance, where the work was actually done. And cannabis use there, which is very interesting. I think you've had talks about cannabis and the effects earlier this week. But there you can see the increasing use of cannabis actually linking to psychosis. The interesting thing about this here, though, as far as I can see here, is if you actually use cannabis just once or twice, you have a reduced risk of psychosis. It's a complicated picture, I think, really, because cannabidiol reduces the risk of psychosis or can be used as a treatment, and tetrahydrocannabinol is, of course, quite psychotic-inducing. So how do we relate this to the synapse? We have a sensitized dopaminergic system which increases salience. So in this room here, instead of just concentrating on me, which I hope you are, you'd be concentrating on everything, the lights, the sound, the noises outside, and that overwhelms the system, so increasing salience. And work's been done upon that. Acute stress precipitates the psychosis, dopamine synthesis goes up, and you have aberrant processing of stimuli, jumping to conclusions. That's one of the most important psychopathologies you get in psychosis here. And you become paranoid, you say, well, what's that about? Development of psychosis, and then, of course, the psychotic episode leads to increasing stress. And our treatment, well, we block the dopamine D2 synapses, don't we? Post-synaptic blockade. I'm going to show you something today that shows that probably outdated our treatment programs. What about this grey matter changes? How does that relate to childhood onset schizophrenia? This is a loss of grey matter in those with childhood onset schizophrenia followed up longitudinally. This is the siblings, actually progressive loss of grey matter until a certain age. So related siblings actually have the same loss of grey matter, but it stops about age 14. Now, everyone's going to be telling you about the synapse. That's not the whole picture, because we know, for instance, that glial cells and astrocytes have a very complex relationship with the synapse. Microglia, for instance, gobble up synapses early. So they're actually responsible for some of the synaptic remodeling. So in stem cell work, which we're undertaking and others are undertaking, we're trying to grow neurons and microglia to show what the relationship is. It's complicated. I get that. Now, this is hopefully the normal developmental IQ that you'd see, say, in you, flattening out as you get older. Those with bipolar disorder, each time they have a psychotic episode, and they can, the IQ drops down. But those with childhood onset schizophrenia and schizophrenia early on, they actually drop off their IQ before they develop the positive and negative symptoms. So that's actually quite sad, and they do not recover. But the important thing is there's a leveling off. But for you as a clinician, you do need to understand that there is a cognitive loss in many cases. Some cases, not so much. And of course, if you've got someone who's very bright, they still may well function above average, but they will have lost a certain amount. So rehabilitating a person to university standard and things like that when they were doing their exams beforehand is going to provide a huge stress for them. And I think this is a really smart paper here by one of my supervisors from my DPhil, is Dan Freeman from UK, from Oxford now, but he used to be in this. But it shows, I always thought you think, oh, well, the paranoid experiences you have in schizophrenia and so on, things like that, and psychosis, they must be discrete. They're nothing to do with you and I, surely. Wrong. This is actually showing that the experience of paranoia is exponentially declined, but it's continuous throughout the population. So there isn't a dichotomy, this group and that group. There is a continuum, obviously decreasing the number of paranoid symptoms you get. I wondered whether this would have been a really interesting study to have done in COVID, because I predict that the whole graph would have been shifted upwards. We all became slightly paranoid, rightly so, but actually the process would have remained the same with a continuous distribution. What about, is it a problem for you and I if you're a community child psychiatrist in Turkey? No, of course it's not, because you won't see that many. But of course you will then see someone and you wonder, what the hell are you dealing with? And this shows why, if you're dealing with childhood onset schizophrenia, it's vanishingly small. But then it picks up. And that graph is an exponential increase. So if you just give me one figure, I can tell you where it is. That's the difference between males and females. Blue males, and obviously pink and red for girls. Sorry to be sexist, but that's the way. But this is actually quite interesting. The early intervention psychosis services, which you have here in Turkey, as well as we have in the UK, developed mainly in Australia. Actually, the founder figure was actually in Oxford, but no one spoke to him, so he migrated to Melbourne and set it up there, so they got all the credit. But what we see here is a huge drop here, between here and here, in admissions for those with psychosis. When I said the other day when I was talking, 20, 30 years ago, I admitted a third of the population, a third of the inpatient care was devoted to patients with psychosis. Now we have 1 or 2 per year, but they're extremely unwell. So the early intervention psychosis services provide medication support, links to schools, and meet with the people in the community. And it works. Let's get on psychopharmacology. Oh my gosh. You say, looking at that, these are the drugs that you prescribe. And no wonder that one patient may well respond to another and maybe not, because the profile of these drugs is exceedingly complex and different. And clozapine isn't a great T2 blocker, but it is, we'll see, the best antipsychotic we've got. So our story isn't complete. And this slide shows that actually you need to blockade the D2 receptor by about at least 80%. Below that, all you're going to get is side effects and not the therapeutic response you want. And that's partly due to the fact that actually we have presynaptic D2 autoregulation, so that actually, as you increase the dopamine due to blockade, then actually this circle continues. Well, would you take the medication if you saw that side effect profile? Not on your life. You wouldn't. These are all the side effects reported in a community sample of adults with schizophrenia. You can see it's not a pretty picture. You're not going to have all those problems, but you're going to have some. It's going to be extrapyramidal side effects and tiredness, lethargy, and lack of sexual kind of enjoyment and so on, things like this. So it's not surprising our patients actually drop out of taking medication. And in fact, that's probably the major problem with taking medication, is the side effects and compliance. But, as I said here, we've got a huge range of receptors, neurotransmitters, affecting different parameters and so on, things like this. So prescribing of antipsychotics is difficult. Do they work? I never understand this meta-analysis here, because it's something like, if my football team beat Plymouth, that's Plymouth Argyle, my football team, if it beat Chelsea once and Chelsea beat Barcelona, then actually by kind of analogy, my football team, Plymouth Argyle, would beat Barcelona. Not in a million years. So, but anyway, so I'm a bit skeptical about this. But nevertheless, they're actually quite helpful. And one of my colleagues spends his life, Andrew Cipriani. Actually, what we see is that virtually all the antipsychotics are better than placebo. That's true. And clozapine is better than all the others. There comes away. We'll see a little bit further about this. Okay. Pathophysiology. So, as we say, you've got a genetic risk here, impaired glutaminergic regulation, striatal dopamine is released excessively, and you get a feedback loop. We've already seen that. I think we've seen this slide before, so we'll just skip that if that's okay. But the important thing here is to remember that in order to stop this cycle, we block the D2 receptors. Is that the best thing? Is it? The question is our treatment moving beyond dopamine D2 blockade? Do you think so? I've got to say, when I look back as a clinician, I think my treatment care pathway, the early intervention psychosis, yes, that's better. But does your drug treatment actually, is that better now than it was 10 years ago? No. So I would go into the no clamp. And have they been doing research? Well, yes, they have actually. But the drug companies are finding it difficult to continue to promote research in this area because of the lack of actually getting a positive response. Your drug companies out there, you see in the foyer, are thinking, well, there we are, and look. Out of 12 molecules, out of 176 completed trials, or ongoing phase 2 and 3 trials, only 12 molecules tested in 42 trials outperformed placebo. So it's not as if the drug companies aren't dealing with our work area. The results are just not there. Have we got something wrong? And the answer is, and this is something I would really recommend that you follow this up, is that actually the problem is shown by PET, positive emission tomography, and Oliver Howes at the Institute of Psychiatry is a name to follow, shows that actually the problem isn't about D2 blockade at the end of the postsynapse. It is increased synthesis presynaptically. That's the problem. So, and he's shown this in a number of studies. It's linked to psychosis. It's not altered by T2 blockade, so you can blockade this. The increased synapses synthesis of D2 of dopamine occurs whether you block it or not. It explains relapse. It is increased and is associated with cortical glutamate. And for your interest, it's increased in 22q11 deletion, but reduced in 22q duplication. So that's interesting. All that summary of work from Oliver Howes' group at the Institute of Psychiatry in London shows that dopamine pre-synthesis, pre-synapsis is where the target is. So we're blocking, we're actually, as they say in English saying, we're shutting the door after the horse has bolted. It's too late. We're downstream. We need to be upstream. Can we take any comfort in our current trials? Well, yes, we can. But we've got to be really smart. Here is a synapse here. And we can alter this through muscarinic, glutamatergic, and I'll show you today a neurotransmitter in here called TAR, trace amines. And this may well actually revolutionize our treatments, but we're still in the early phase 2 and phase 3 trials. So we want to, just to recap, we want to reduce the presynaptic dopamine synthesis rather than D2 blockade. And first of all, Well, actually, we always thought the limbic striatum was very important in psychosis. Apparently, that's all completely wrong. With higher resolution PET, we now know that the pathways are in the associated striatum. And that makes a difference, actually, because if you're targeting the wrong part of the brain understanding and things like this, then you're way off target. So actually, more refined PET is showing us that actually it is the associated striatum, not the limbic striatum that's involved in psychosis. And this explains why, when you prescribe your patients an antipsychotic, actually have different side effects on different profile, different brain systems are involved in here. So you get galactorrhea if you tubular infundibular pathways, but you may well get extrapyramidal stiffness and so on, dyspraxia and so on, dystonia, if you actually find a nigrostriatal pathway. So actually, it may well be that your patients respond better to different drugs. And it's rather a blurred slide. I do apologize for that. I tried my best. But actually, what we're showing is that certain areas of the brain have increased dopamine and glutamate, that's striatum there, and actually the frontal cortex has seemed to me the almost opposite kind of profile here. So while a dopamine blocking drug might well affect one system, it's actually making another system, cognition and so on, things is actually worse. And the pathway here now is that we think lower cortical glutamate here, due to the excess synaptic pruning in the frontal cortex. Remember we showed you that graph and actually showed you in childhood onset schizophrenia, the loss of gray matter is greater. So here we are here, leading to GABA in changes, and so the pathway continues here. And the ultimate link round is increased dopamine release due to increased dopamine presynaptic synthesis. So the control is not just with dopamine, it is with glutamate and GABA as well, with the interneurons. So it's a complex pathway. And here comes the star of the show. Because this is you, normal, in terms of dopamine. I mean, if you smoke cannabis, you can have increased levels of dopamine, but let's assume you're not doing that right at the moment. Well, I hope not during this lecture, at least. But in schizophrenia, you have increased dopaminergic release due to increased presynaptic synthesis here, leading to a hyper-alert, hypersalient state, made worse, for instance, by stress, urban living, we've seen that, having a father over 50 or 40, and taking cannabis. Now, what we can now do is actually a D2 antagonist here. This is what you do currently, is you block this here, and that leads to a problem because the D2 autoreceptors here are also blocked. So you're actually, at the same time, taking your foot off the brake, but then putting it back on an accelerator as well at the same time. What you can do here, what we hopefully will be able to do, is use a TAR, which is trace amines, a drug that actually specifically works intracellularly and blocks presynaptic dopamine release. When I was asked to give this talk, they said, we want up-to-date information. This is relatively up-to-date. So the trace amines, they're endogenous chemical messengers, structurally similar to the monoamines, expressed at. Now, the reason why we haven't actually found these before is because they're very, very low in concentration. That's why they're called trace, 100 times less. But the interesting thing is they act presynaptically, but unlike most of the other transmitters that you talk about, they actually work intracellularly. And actually, that's the kind of hallmark of these medications. But the effect is they can actually modulate presynaptic function, dopamine release, without dopamine blockade, and it modulates the other neurotransmitters. And this is it. You don't need to remember the name of this particular drug, but it's Ultraront. been tried here, and it's shown that actually reduces positive and negative symptoms. And the important thing is actually it continues to do so after the double-blind trial finished here, and the side effects were minimal. And this is the results here. You can see it's always nice to see the graphs here, showing that it has a positive effect at 6 weeks. But this is a double-blind part of the trial. Most trials have a certain length of time, say 8 weeks and so on. But the important thing is they continued single-blind, or they continued the trial to show that actually the effects of this TAR agonist continued. And the side effect profile is not too bad. Now the question is, many people will ask, how quickly do you have to see, can you see the effect of the antipsychotic? Because the teaching is for early intervention psychosis, if you've got medication, you need to be able to continue that medication for stop, and then start another one, and then go to clozapine. Well, you need to know how long it is. And the answer is probably at least 3 to 6 weeks. It is not longer than that. And this is, I recommend this paper to show that actually with the various antipsychotics, you see a change from placebo response to effective response within about 3 to 6 weeks. Oh my gosh, this slide would be familiar to you, showing the absolute devastating effect certainly antipsychotics have upon weight gain. Well, olanzapine here now, NICE guidelines in the UK, ban that as the first line of treatment because of the weight gain is huge. I had one patient, we gave it, and within hours she was going down and actually having 6 teaspoons of sugar in her tea, and she never had that before. I didn't know exactly how it worked. I thought it worked centrally, but actually it works peripherally as well on the pancreas, reducing insulin release as well. How do you manage that? I think dieting and exercising and things like that is probably worth trying, but it's probably useless. Well, you need to do that, of course, but actually what you need to do is prescribe metformin alongside that, and actually you need to do a reasonable dose. We had one patient who actually increased his weight by 50 kilograms. Can you imagine that? That's ridiculous. And I'm hoping that we will be able to use a semaglutide to be able to reduce that, because it's just not fair. You're increasing the risks from cardiovascular problems for him. Anyone want to answer this question? Don't worry. Do you know how many RCTs there are for clozapine? Sorry? Yeah. No, worldwide. Adults as well. So what are you going to do? There is no evidence that in terms of randomized controlled trials. This is an alternative way of doing, which I think is actually better. Randomized controlled trials means you select a population. They are highly select, as I said. They may well not be suicidal. They may not necessarily be representative of the population that you're treating. But if you take a whole population survey, then you're going to do this. So our Nordic cousins, and here we're talking about Finland and Norway, at least my geography points that out. Sweden and Finland, not Norway. I do apologize. Actually all of the Nordic countries have a database so that if you come into the hospital, it's recorded, information is recorded, and it's linked to other health outcomes, which you'd expect. But it's linked to other things like car crashes and financial status, the whole lot. So it's actually quite complex. And I think Denmark and other countries are also involved in that. So we can look at the effect of clozapine on that, in that population. And I recommend this paper so that when I was surprised to see, is there any trials in RCTs in clozapine? This is a paper I would recommend. It's in the Lancet this year, so it's not that old. And this is looking at the analysis from randomized controlled trials. And if you look, olanzapine's at the top there. not clozapine. But if you look at the registry, that's whole population surveys, you actually find that clozapine is at the top, along with olanzapine, long-acting. Now, I know we're looking at child and adolescent services here, but actually one of the things I would recommend if you've got poor compliance and someone with a major psychosis to think about using long-acting antipsychotics early on. Because it's having breakdown in school. My understanding is that a school will be accepting of a young person having a psychotic breakdown once, twice. After that, it's not going to work. And this is the combined trials here. So just to go through that, the gray represents drugs that have only been available in RCTs. And green were only available in registry trials. So you can see here, I'm quite interested to use arsenopine. Has anyone used arsenopine? It's quite complex to prescribe, I think. You have to use buccal kind of dispenses, prescription, but there we are. And actually, one of the things you get there is long-acting antipsychotics. They've been evidence in both trials. So this is a slide you'll be totally familiar with, showing you the complex genetic profile of those with psychosis. I think this was 108 when that first came out. It's now about 176 or even greater, and actually being replicated in European and Far Eastern countries. So it's pretty clear. But one of the things stands out initially, which was a bit of a strike, was actually the importance of the immune system in this schizophrenia profile. And actually, it might make sense in terms of clozapine, because clozapine actually affects the immune system. So does some other antipsychotics. So does it affect this, rather than just dopamine D2 blockade? A trial we're being involved in right at the moment, well, it may well answer that. So when you're trying to persuade your patient to take clozapine and your colleagues to take, for their patients to take clozapine, and this is an uphill struggle. I suspect it's true in Turkey that actually if you look at the uptake of clozapine in Turkey compared to what the rates of treatment-resistant schizophrenia, there's a big disparity. And that's due to physician problems. Because if you look, reduced suicide rate, reduced mortality, reduced rate of violence and violent crime, and reduced readmissions to hospital. Now, all those papers I've given you the references to are reasonable papers done by leading centers and in high-impact journals. So the data is pretty strong for clozapine. And the epidemiological evidence that I showed you beforehand shows that clozapine actually works well. And some people say, oh, it's just because you've got follow-up, because you have to take regular bloods and things like that. If that's the case, that's the case. But whatever it is, if you have patients with treatment-resistant schizophrenia, clozapine is the answer, even early on. I wanted to show you a couple of slides. Is that okay? Can you hear this? We need to turn that up. So, I don't know, would you be able to hear this through the speakers? Hopefully you can. What Dan Freeman has done has actually developed a FAR. It's called experience where you wear a headset, an Apple headset, and so on things like this. And you can see this. The patient goes through with paranoid psychosis, and they're asked to just think and record their findings at this particular point. So the patient would be asked to just view this slide and actually record the thing, so that actually with support with a therapist, they're able to reduce their paranoid feelings and things like this. And it actually works. They can use it for patients with agoraphobia and phobia and so on, things like this. All the things that actually, when you look at it, you wonder why that person's moving their foot and things like that. If you remember early on, I said to the patients when they become increasingly dopaminergic state, then increasing salience, so that everything you see on that slide becomes infused with an extra meaning and jumping to conclusions. So if you can actually use a cognitive control, that would help on that particular point. Should we move? Do you have that available in Turkey? It actually works really well. Okay, can we go to the next slide? So this is a young patient who actually had anorexia nervosa, not psychosis, but I think it absolutely brilliantly describes how the patient feels. So hopefully we can hear this with one way up. That's great.
At first, when I started hearing voices, they said things like,
"The hell to get you? What are you doing? You're always getting it wrong. Be careful what you say. You can't trust anyone."
yeah, just like that. I tended to believe them, and it made me feel suspicious and paranoid.
Yeah, you should be suspicious. Don't tell anyone anything. I'm looking out for you. I'm the only one you can trust.
I really wasn't able to distance myself from them.
You don't need to be distant.
When they were talking all the time,
They're not interesting.
I
You know you're not interesting.
I found it really hard to concentrate.
You don't need to.
Tried to send them away,
We're not going anywhere.
or ignore them,
Wait, so now you're
or argue back. Shut up! I don't need to listen to you anymore.
You do need to listen.
I
You
found it
will
really draining
listen.
and
They
exhausting.
want to get rid of me. They want you to get rid of me. Listen to us. Why are you telling them?
And when
all
I
this?
couldn't get rid of them, it was totally
You can't trust
demoralising.
them. Watch your back. Why are you telling
You
them?
can't
trust them. Watch your back.
I worried that I would never get better. In therapy, I learned, rather than fighting with the voices, to find a way to make peace and distance myself from them. For example, giving them names to take some of the sting out of it, or thinking of them as annoying friends constantly giving advice that I don't need to listen to. I learned to think of them as background noise, like the radio on in the kitchen. This makes me feel a little more in control, and my voices don't affect me so much. I'm able to get out and do the things I used to do before this started, like meet up with my friends or dancing.
I don't know how you think that. I hope it comes across in the translation. But the idea being that you can see how confusing and disturbing having multiple voices all the time arguing, you've got to do this, you've not got to do this. And that is a common part of the psychotic experience. And the idea of the CBTP, cognitive behavioral therapy for psychosis, is that you don't fight it. You accept it, but actually what she did very cleverly there was to name it two names that actually are ridiculous, Edna and Gladys. Edna and Gladys are truly English names, but they're very old and really stigmatized. If you're Gladys, you think, oh, that's a strange old name, and Gladys. So you name them names that actually are slightly derogatory, and then you can say, Gladys, keep quiet. Edna is talking, and so on, things like this, and actually it works. And the evidence is that actually CBTP works well. It works well in acute psychosis and so on. You can see how it works and how useful it is, but in combination with medication. We carried out a trial that was reported in the Lancet in 2022, showing that we randomized to three parts, a multi-center trial. One, you would have CBTP only, first episode psychosis. The second one, you'd have medication only, or the third one, you'd have medication plus CPTP. And actually, there was no difference. No, a non-inferiority trial, there was no difference at all. So if you, as a psychiatrist, psychologist, actually have patients with first episode psychosis, you're perfectly justified in treating the patient with with CPTP, first of all, without having to resort to medication. It's quite a difficult trial to do, because many physicians would say, I've got to get medication. That's the treatment of choice. I've been taught that. But actually, the evidence is not there for you to make that kind of assumption. And actually, what we showed was that actually, unless there are acute risks, you can trial psychological treatments first or combination. The evidence for psychological treatments is accumulating. There's a Cochrane review showing that actually it works. Other treatments which we need to mention here today are autoimmune causes for psychosis. My lead professor in Oxford, Belinda Lennox, has actually talked about an autoimmune disease that you can get, often presenting with acute psychosis but neurological problems and things like that. And actually it's worthwhile for any patient first presenting to do blood-brain antibodies, potassium voltage change antibodies and things like this. But you have to do them in a research center, because if you do the routine ones, it's going to come back negative. It's worthwhile pursuing, because the treatment there is completely different if that's the case. You know. But actually, I've got to say, although when you talk to experts, they say, yes, you've got to do this, and a number of patients will have that profile. In practice, I don't see that, but if you have had that experience, the only experience I've had was a young boy who came in with acute psychosis, and he was treated and did quite well. And his mother said, can I take him down to town? And I said, yes. And actually, he was much better. But actually, as I noticed, as I was saying, yes, you can go down to town, his eyes began to flicker a little bit. Anyway, she came back, and by the time he'd come back, he was completely psychotic and actually had to be treated with ECT, which was a great shame, but he recovered. But as a young adult, he was referred from a team in southwest of England, and blood-brain antibodies were done at that time, and they were extremely high. And Belinda said, I'll see him and treat him. But the physician didn't really want to do this, and the boy killed himself, which is a tragedy. At the time when I saw him, this was pre the news about auto antibodies. When he became an adult, that was there. So actually, it's worthwhile doing that on screening every single patient. So I hope I've taken you through some of the treatments here. These are the problems with clozapine, and that's true. But actually, the important thing is that you do not get all these side effects, but enough of them to make life really uncomfortable. So the kind of pharmaceutical dream is to make sure they can get something equivalent to clozapine that doesn't have these side effects, and they are considerable. This is, I put in, but I think this is for trainees, not for you, showing that actually measuring the QT interval is actually quite important, and that's how you do it. There's nothing more, I think. I tried to finish within time today. Okay, thank you.